Entonces, le vamos a pedir al doctor Edward Félix, que es director médico del programa comunitario bariátrico y profesor asistente de cirugía en Fresno, California, pero hace un rato pues, decía que ya no está o no vive en Fresno, California. Bienvenido, doctor Félix. Él nos va a hablar de la derivación de ayuno ideal, ¿por qué no?
Well, it is a pleasure once again to be in Mexico. I think it's my second home now. The next 12 months I will be here 4 times. So as one of the surgeons said, I should buy a house here. That's the next move. But I've been asked to talk about metabolic surgery, and I've been asked to talk about Arroyo de Palo's operation, which is basically ileal imposition. It's a little difficult for me to do that. It may be a good operation. Arroyo is a fantastic surgeon, and the other surgeons who do this operation are unbelievable surgeons. But in the United States, it's totally experimental. Nobody is doing it except on an experimental basis, so there's no data for me to debate. So what I decided to do is say, well, what is a similar operation that is being done in the United States, and help out Dr. Rumbaugh, who's about to debate Dr. Beltran, and kind of debate the DS instead. So I'm doing what we call a switch in the United States. So I'm going to say, why not do the DS? Because it's similar. It's got a lot of the complications that Arroyo's operation has. And I'm going to show you why I don't think we should do that, and I would support Samir and say we should be doing the gastric bypass. And I'll go back, if I can go back one. That picture is actually not someone I gave this lecture recently, and they thought that was my home. That is not my house, that is my new hospital on the central coast of California. I wish it were my home. So the DS, does it work? There's no question that the DS works. You're going to see data from the next person presenters. The longitudinal gastrectomy, we do it, they don't switch. It's safe and effective. This is an article written in 2003 from USC, the group that was doing many of them. And they showed it was, they said it was safe and acceptable, it worked well, and then they said minimal side effects without developing significant dietary restrictions and clinical metabolic nutritional complications. And I want you to remember what they say here, and this is in 2003. So remember the authors, remember what they said in 2003, because these same authors will mature in 2010. In the Annals of Surgery in 2004, people were getting a little more skeptical about the DS. The data suggests great weight loss. However, PPD and DS was associated with a longer hospital stay. They didn't say why, but obviously if the patient stayed in the hospital longer, it means there's something wrong. And that wrongness is complications. Then a little bit farther, 2010, the laparoscopic nuclear switch resulted in greater weight loss. However, patients in our series had more frequent gastrointestinal side effects, required greater doses of vitamins and calcium, and required more post-operative monitoring. That was a gentle way of saying, again, they're having complications. Because most patients we do bariatric surgery go home in 24 hours to 48 hours. They don't have monitors. Then if you look at 2014, And you can see, it's just like any of these new operations. As Dr. Matara said, you can't judge them too early because as time goes on, we learn. We learn from our mistakes. And what we see now is in 2014, operative time and length of stay were significantly longer after DS, as well as the risk of post-operative leaks was significantly greater with the DS. So they said in their article, this comes at a price of more early complications and possibly more mortality. So at 14, they're kind of going, well, it's sort of like what we're doing with the band now. We've kind of put a band, everybody was on the bandwagon. Now everybody's band, right? The same thing is true of probably this operation. So, is the DS worth it? The surgeon must weigh the risk of the benefit. If you only get a few % better benefit, but a much higher risk, is it worth it to do it? Would you do it to your mother or maybe, like it? Would you do it to your mother? Would you do it to a relative? Is there an equal operation or a better operation than the DS for solving the metabolic problems? Does the alternative operation, which may be equal or a little bit less effective, have much less risk long term? And finally, if you have a problem with your operation, how easy is it to revise it? So risk benefit. And I think every person you listened today to who got up here before me, you should weigh in your mind risk benefit. Is it really, it's like buying stock. Is it really worth it to take that penny stock and throw your money in there? Sure, you may make $1 million, but more likely you're going to lose it. So it's risk benefit. Possible benefit, they have a greater weight loss. Higher BMI patients, lower BMI patients, there's no question, they do well no matter what you do. Higher BMI patients may have a greater weight loss, may have a longer lasting diabetes control, that's probably true. And there's no dumping. I don't think dumping's a bad thing, but they say there's no dumping. What's the risk? First of all, if any of you operate on patients who've had to be revised as patients with DS, you know that many of them have such gas that they will clear this room out. Not all, but many. Many will have uncontrollable diarrhea. They don't tell you about it because they begin to accept 4 and 5 and 6 bowel movements a day as normal. But it is a problem. The real problem, however, those are minor to me. The real problems are the long-term deficiencies, and I'll show you why I think that's a problem. Protein deficiencies, vitamin deficiencies, the fat-soluble vitamins, DA, K, and E, Bs, B12, thiamine, folic acid, and iron deficiencies. The real problem with the DS patient is we know from our data, from Dr. Higa's data, if you look at the Higa slide, only 18% of his patients had 10-year follow-up. They lost almost, 18 from 100 is what, 82% of the patients disappeared. So the problem is, if you look at data, you're really not seeing the real data. The long-term follow-up is not there. And when DS patients disappear, they get into problems. 50-75% of patients will disappear. Patients don't take the vitamins or the protein supplements. And not all of them, many of them come back underweight, severe protein deficiencies, severe anemia, osteoporosis. The problem is, they don't always come back to the person who did the operation. And if you look at, here's that article from USC and Dr. Crooks's group again, patients requiring revision of DS for malnutrition, so on and so forth. 10 years. 33 of the 701, 5%. Looks like great results. But that's not a real result because we know that they're only seeing about 25% of their patients back. The other 75% are disappearing. And if you see if you're only seeing 25% back, and those 25% have a 5% incidence of severe problems, that means you have a 20% incidence of severe problems in all those patients that you're not following. And that's my fear. It's not that it's not a bad operation. If you could be like the Dutch or the Swedish and everybody is forced to come back, it'd be great. But in Mexico and in the United States, we lose 75% of our patients, and they get into problems with protein malnutrition, abdominal pain, metabolic problems. So, should you do the DS or should you do less? This is Tweedyberg. He had a DS, and he's coming to my office now. He wants a revision because he's lost too much weight. So I want to thank you for letting me speak today. To make all of you jealous, I have moved to the Central Coast. This is the view from my bedroom window. Thank you very much.
Muchas gracias al doctor Reyes. Enseguida continuamos con el doctor Gilberto Uso, derivación fibropancreática,